So he has a liver-confined tumor, and it's very reasonable to consider local regional therapy. Strictly speaking, by the Barcelona criteria, this patient might be considered Barcelona C, given that they have performance status of 1 and symptomatic disease. But again, it is confined only to the liver, and local regional therapy, I think, would be considered by many physicians and multidisciplinary tumor boards as something to consider. So as we learn, the patient undergoes a chemoembolization procedure. The majority, I think, of the patients we see in managing this disease do present with disease that is treated with local regional therapy. And in that regard, interventional radiology is a key component of any multidisciplinary tumor board. As we learn in this case, the patient had a chemoembolization. Chemoembolization has been shown to improve survival in patients with organ-confined disease, though typically a patient with this size tumor would have been excluded from the randomized prospective studies that showed a survival benefit with TACE. But needless to say, they undergo local regional therapy, and we learn on follow-up imaging that there's residual disease and perhaps some residual satellite lesions or even new lesions. The question is, what do we do next for this patient? I think seeing a 12-centimeter lesion on a scan and in sending that patient for local regional therapy, most of us would not expect them to have a complete response to one round of TACE. A lesion this size likely would require more treatment. The question here is, should we do another TACE or move on to another treatment option? Keep in mind, in the United States, largely TACE is not done with a predetermined number of TACE. Again, that is different from the prospective randomized studies that evaluated TACE, typically had a pre-described sequence of chemoembolization regardless of response to the first TACE. But often in the United States, we'll do a TACE, get some imaging a few weeks later, and if there's residual disease, proceed with a second or third or fourth TACE, etc. I think given the findings on this patient, assuming there's still good performance status and medically amenable to a TACE, then it would be reasonable to consider a second TACE. The one red herring here in this case is the fact that it's possible they have progression with new nodules. It sounds like they're small and maybe indeterminate, and in that regard, we could give them the benefit of the doubt and consider another chemoembolization and repeat imaging after.